Okay. Good afternoon, everyone. Welcome to this 53rd ECO session. We are so glad to be back here once again to share knowledge to help our patients in emergency care. Like you all know, it runs from 2 to 4. We shall ask that we all keep muted. You can raise your hand if you have a question or drop it in the chat room. Someone should be able to get to you as soon as possible. And in case we are not able to answer your question, then we shall do it in session. So at this point in time, I want to introduce our session, and we are going to be looking at abnormal ECG rhythms. I know very, very many of us have seen these strips and wondered, what are those waves? Why are they there? Today, you're going to know why they are there. To some, they may be new. To others, they may be old. It's not going to be in-depth, but all you want to do is for you to be able to identify them and refer these patients for specialist care. So at this moment, I'll ask the experts and the case presenter to introduce themselves. I'll start with the gentleman on my extreme right.
Good evening, everyone. Thanks, Dr. Connie. My name is Dr. Ndawula Moses. My residency is Makerere University. I'm so glad to be on this panel.
Thank you, Moses. I'm called Connie Baluka, an EM resident from Makerere University, and I'm glad to be back to EM.
Yeah, good afternoon, everyone. Yeah, it's an exciting moment for me personally to be part of this team of panelists that's going to be talking about an important topic that strongly relates to what we do in the field of emergency medicine, cardiology, and really primary health care. So over the next couple of hours, we are hopeful that along the discussion that we're going to have, you'll pick out a lot of things that are going to help you in your day-to-day practice. And we hope that you use the knowledge you're going to pass on to optimize how you look at patients with cardiac arrhythmias, how to know that this is a particular rhythm that I need to manage on my own or make a referral for. Yeah, so my name is Dickson Kamoga. I'm a resident of emergency medicine. My interests are point of care ultrasonography and ECGs. So I'm glad to be here, and thank you all for being with us.
Ms. Bethel.
Good afternoon, everyone. My name is Bethel Mwenze. I am the training site coordinator for American Heart Association here. I work with Samaritan Health Systems. I'm very excited to be a part of this panel, and I will be, I guess, giving my expertise on pre-hospital personnel and how they should approach patients this way.
Thank you, moderator. Hello, everyone. I'm Mugumya Donanto. I'm a critical care nurse for Samaritan Health Systems, Nakasero Hospital. I'm also an American Heart Association, BLS, STLS, and PULSE trainer. Nice to host me here.
Okay, thank you so much. I'll ask Dr. Bagonza to unmute and introduce himself. Dr. Bagonza, are you there? Okay, we shall get to it when he gets online or when he unmutes at any point in time. As the norm is, at this point in time, we want to find out what do we know about ECG rhythms that are abnormal. And this is in form of a pretest. It will run for 15 minutes. Please, ICT, share the poll questions. If you're not able to see the poll questions, kindly put it in the chat. We should be able to sort you in a sec. You can also share with us your expectations. What do you hope to learn by the end of this session? What do you know already And what do you think is interesting about the ECG readings? Please don't forget to share with us your expectations, what you hope to learn from this session. Just a brief one.
Thank you. My name is Mbarara. I work here at Seed Global Health. And Seed Global Health, together with the Ministry of Health, host these sessions and have been doing so for about 3 years now. And today, I would like to thank you, our loyal participants, who have been with us this long, who have joined us in yet another year. And this phase, which is phase 4, has about 26 sessions that will take us throughout the year and cover systemic disorders. As we know, systemic disorders covers all systems in the body. So it's not the same thing. Every 2 weeks, we can be having a different session, probably from a different system. So prepare to learn this year. And also thank you for keeping with us and advancing emergency medical care in the country. Thank you.
Dr. Mary Ellen, your hand is raised. Please unmute and say something.
Hello, everyone. I'm glad to be here today. I just wanted to say that I'll be online and trying to answer questions that are posted. There's a question and answer tab, and I think it's easiest if questions are placed there rather than in the chat. The chat seems to get awfully full. I'll try to keep an eye on both of them. But please feel free to post whatever questions you like, and I'll do my best to answer them on the Q&A tab, and then the ones that seem like of the most general interest, then hopefully the moderator and panelists will speak up and address to the group as a whole. Thanks.
Thanks so much. There you go. So the Q&A panel, I hope we've all seen it. It's at the bottom of our screens. Please place your questions there and you'll get a rapid answer in session. Thank you. So, thank you so much, Raymond. I'm glad you have an expectation of learning how to interpret ECGs. We are going to do it briefly, but we shall talk with Brian and see how to have a whole solid echo session on only interpretation of ECGs. But we shall do a little bit of it. Our experts will also guide on the expected maneuvers for some abnormal rhythms. So let's get the whole things clear. Okay, so the poll has been closed, members, and thank you so much, participants. So right in, we shall dive in with the clinical presentation. So Dr. Moses will be taking us through a patient clinical case. Please listen to it because it may be one of those patients you've seen before. Thank you. Dr. Moses, you're welcome.
Thanks, Dr. Baluka, our moderator. My name is, as she mentioned, I'm Dr. Moses Ndawula. I'm pursuing Masters of Medicine of Emergency Medicine at Makerere University. I'm here to present to you a case presentation on a patient with cardiogenic shock. Next slide. She was NM, a 40-year-old female, a non-patient with rheumatic disease and heart failure, who was on oral Lasix, spironolactone, warfarin, and sacubitril, valsartan for over 3 years. However, she had poor drug adherence. She was brought to A&E on 11 October last year with 1 week progressive worsening of shortness of breath, exertion dyspnea, palpitation, general business, hallucinatory dyspnea, and lower limb swelling. However, there was no previous loss of consciousness or any convulsions. The group analysis systems were unremarkable. Assessment of primary survey, our airway was patterned, which was able to talk. Our spine was intact. There was no features of injury. On breathing, she had obvious respiratory distress with lower chest blowing. She was tachypneic with a respiratory rate of 42 beats per minute. She was desaturating at 75 saturated room air. However, she had bilateral air entry. There was no crackles, no bronchi. Because of the hypoxia, we had to supplement her with oxygen. We started out with 15 liters per non-breather mask. That's how we optimize the breathing. However, on saturation, she was in shock with cold extremities. She had the descended venous, jugular venous. Our capillary fill time was delayed more than 4 seconds. She was tachycardia at a rate of 154 beats per minute. Of reduced movement, however, it was irregular. She was hypotensive with BP of 66 over 29 millimeters of mercury with a map of 49 millimeters of mercury with the same JVP. However, sounds were heard with a mama at the mitral. Because it was in shock, we had to start with field, so we started with 1 liter of normoxidine. We had to vasopress her with norepinephrine, started at 16 microgram per hour via the infusion pump. Also, together with the vitamin, 6 microgram, we targeted to take the map. Our target was have a map of about 65. However, at that junction, the blood samples were taken for the CBC, renal function tests, and Samaritan. In our disability, she was alert, the asthma score 15 out of 15, pupils were equal, reactive bright. Our non-blood sugars was 3.1 millimeters of mercury. I think something we had a new intervention. On our exposure, she had cold extremities. She had anuria for over 24 hours. She hadn't passed out in urine. However, per abdomen, she had abnormal fullness, no various abnormalities. At this sanction, because we had studied the fields, we left capitalized. Sample for the analysis were taken, also RFPs were taken earlier on during saturation. In our sample history, as explained by previous slides, symptoms and signs, she had shortness of breath for over 1 week, with palpitation, deficit, chest pain, dull in nature, non-radiating, with aphyphonia, exertion dyspnea and lower limb swelling. However, with anuria for over 24 hours. On our ARGs, there were no known food allergies or drug allergies. On medication, she was currently on Lasix, 40 milligrams, Sapinactone, 25 milligrams, warfarin 5 milligrams, Sopro 5 milligrams, and Sacopitrol was certain combination. However, she had poor adherence to medication. As medical history, in the past 1 month prior to the admission, she had 2 admissions. The first admission was on 12.
Thank you.
Last year, where she was admitted at cardiology ward, at least where she was being managed for rheumatic heart disease with severe atrial fibrillation and acute compository heart failure. However, she was there for 3 days and she was discharged on improvement. Then after it took 3 weeks, she was admitted by the medical emergency with the similar symptoms of heart failure. She had severe atrial fibrillation with acute kidney injury. By that, she hadn't passed urine for over 3 days. However, she was admitted at cardiology ward she was spent there for 1 week, for almost 10 days, and she was discharged on 15th October last year. On improvement, she was able to pass the urine. Also was improving. However, last May, by the time she had taken us previous supper, after there was no events or next slide. Our investigations, we did ECG on admission, which was suggested features of atrial fibrillation with marked right axis deviation, with ventricular tachycardia of 1. With ventricular tachycardia, however, she has a rate of 1.6. In our kidney function test, she had a waste creatinine of 2.9, like twice the upper limit. Also, our area was elevated, like 4 times more than upper limit. She had hyperkalemia of 6.68. But our sodium was okay. Our RFTs, our liver function tests were elevated. On the complete blood count, she had marked leukocytosis of 21. She had necrophilia of 18. She had hemoglobin of 8.3. And she had neutrophils of 136. Our blood sugars on admission were 5.6 millimoles per liter. That was our ECG findings, which were typical of atrial fibrillation. Maybe can you try to modify?
We shall share the ECG imaging. You can proceed.
Our problem is she was an only rheumatic heart disease with severe atrial fibrillation, with acute compository heart failure. Some diagnosis we were querying acute kidney injury with hyperkalemia. It was in cardiogenic shock with septic shock, in the view of hypotension, delayed capillary refill, in cardiac extremities, and also the CBC was suggestive of features of sepsis because we had the leukocytosis and neutrophilia. Treatment and follow-up. Patient was brought to A&E on 11th October last year. However, the following day, the patient was transferred to medical HDU. However, by the time he was transferred to medical HDU, was still in cardiogenic shock, irrespective of the vasopressors which are given the norepinephrine and the betamine. The BPs were still low. The stroke was 65 and the stroke was 638 millimeters of mercury. She had tachycardia of 154 beats per minute, but it was reduced volume and it was irregular. Still having low map low arterial pressure of 53 millimeters of mercury. The capillary fill was delayed for more than 5 seconds. She was tachypneic at the 30 beats per minute. She was saturating at 96% on non-liver mass at a rate of 15 liters of oxygen. She was fully conscious with a small of 15. However, ECG was done, so was suggestive of fetal overture population. However, by then, since the patient was not responding on the chemical chemical cardioversion, we discussed with the team. We just decided to have electrical cardioversion. In this case, the patient was sedated with the ketamine, 100 milligram. We performed the synchronized cardioversion. We shocked the patient with 100 joules. However, the normal sinus was sustained. However, the patient after, then we continue with the vasopressors, norepinephrine. However, after 18 minutes, the patient arrested with pulseless electrical activity. However, CPR was initiated, was given adrenaline bolus 1 milligram every 5 minutes. The patient was intubated. However, we sustained a pulseless ventricular tachycardia. We defibrillated by biphasic defibrillator with 200 joules. However, the patient arrested 3 times. Now, unfortunately, was unsuccessful. We lost the patient. And that's the presentation. Hand over to the moderator.
Thank you so much, Moses. It's unfortunate we lost the patient, but we shall learn from the patient. So we have 3 questions that we're going to answer. The rest should be directed through the Q&A. And Ham was asked which dose of dobutamine was used.
Dobutamine?
Yes.
It was 60 microgram. It was 5 microgram per kg per minute.
Okay. Briefly, they will tell you all those drugs. And then Farah was asking why were fluids given to this patient?
Why the fluids were given? However, we gave the maintenance fluids. That's why we gave normal sun, we gave 1 liter. However, we are still contemplating about the kidney injury. And also, the patient was in shock, was dehydrated. We had to give some maintenance fluids. That's why we gave the fluids.
Okay, so Farah, fluids were given because the patient was in shock. Okay, so lastly, Royalyn wants to find out what's the likelihood of arrest if the cardioversion hadn't been done.
I think she's just preempting the discussion. Dr. Kamoga will talk about it.
Okay, so like we had said, we shall take 3 questions. And for clarity, our experts are going to tackle everything. So sit tight, grab a bottle of water and listen in. Straight away, we're going to welcome our first expert presenter, Dr. Kamoga Dickson, who is going to take us through the introduction of what are abnormal ECG readings. He will categorize them for us. And finally, he will give us a general approach of how to approach such a patient in case they appear at your health facility. You're welcome, Dr. Kamoga.
Yeah, thank you, Connie, and thank you, Ndawula, for taking us through the case presentation. So, like Connie has said, my presentation is going to drill on really giving you an overview of abnormal cardiac rhythms. And I'll go over the classification of cardiac arrhythmias. And finally, I'll do an introduction of EKG interpretation for cardiac arrhythmias. Then the next bit of the topic presentation will be done by another expert who join us online. So, Jerry, if you could project my presentation. Okay, so to just briefly introduce it as they project my presentation. So what are abnormal cardiac rhythms? From how the heart is structured, we do have a conduction pathway that originates from the right atrium, spreading all the way down across the atria to the ventricles. So that's what the conduction path of the heart is. So from what the sun is, which sits in the right atrium, impulses cross over to the atria, to the left and the right atrium. Then via the AV node, they connect down to the ventricles. So anything that impairs that conduction pathway is what we call a cardiac arrhythmia. So in simple terms, a cardiac arrhythmia is any abnormal heart conduction that will give the heartbeat an abnormality. So I have quite a number of presentations, but I've structured it in a way that I'm going to do about 30 seconds per slide. And I'm hopeful that within the next 30 minutes to 40, I'll be done with my presentation. So for the, Jerry, next slide. So I've defined what a cardiac rhythm is: anything that is an irregularity within the heart conduction that can either cause the heart to be slow or too quick and make the heartbeat abnormal. So that's the cardiac conduction pathway that I was talking about. So from up here, where we see the sinoatrial node, that's where the pacemaker, that's the pacemaker for the heart. That's where the impulses are generated. They flow over the internodal bundles to the AV node across the atria. So the AV node is that other white, yellow, huge structure that you're seeing there. Then from there, impulses cross down to the ventricles via the bundles, the right and the left bundles. So what we see on the right is a single heartbeat, and each wave, as they're labeled, corresponds to a different action in the heart. So the first wave, which is labeled P, is where the atria are contracting, and that's what we see up in the right atrium, where fibers are crossing over to the left and the right. So there, after the P wave, we see a flat line. That's a point where impulses are within the AV node, which is like a point of grounding things. There's no net flow of impulses within the heart at that point. So that's why we see a flat line, and it's what we call an isoelectric line. At that point, the heart is actually rested. There's no electrical activity in it. So from there, then the ventricles have to start contracting. So when they are doing that, so when the ventricles are contracting, that's when we see this nice QRS complex, which starts from down here, going all the way up to the R wave and the S wave. So that's the QRS complex. It represents electrical flow within the ventricles. Then we see another flat line at that point before the heart goes into relaxation again, before the ventricles rather relax. So that's the ST segment. So at that point as well, there's no net flow of charge within the heart. So after the ventricles have contracted, and it's what is represented as the QRS complex on the EKG, then we see a T wave, which represents repolarization or relaxation of the ventricles. So that's the single beat of the heart. So each time the heart is going to beat, those particular events are happening from the P wave to the T wave, and the net flow of charge or electrical impulse is as structured here in the yellow lines that are represented here within the heart. So I'll go over what common causes of cardiac arrhythmias are there. So like I said at the introduction of it, cardiac arrhythmia is a common pathology. And, across all the different fields of medicine, this is a common condition that we all tend to manage, because the causes are really diverse, and they range from things that we can correct immediately with the patient or things that the patient has for long lived with. So for the things that really happen immediately and they can cause a cardiac arrhythmia, the common things that we talk about, electrolyte imbalances, these are really correctable even by the bedside. So for a primary care doctor, a nurse, a clinical officer. These are things that you should be able to recognize and manage before you even make, a decision to refer the patient, or you institute management for as you arrange for referral. However, there are also other causes that are really kind of permanent and are managed at a tertiary level, and those are things that the patient really lives with, but they can precipitate an episode of a cardiac arrhythmia. So those are commonly structural heart diseases or valvular heart diseases. So one of the commonest ones is the hypertrophic obstructive cardiomyopathy. So a patient who is living with this is at risk of getting a cardiac arrhythmia as well. So a heart attack, so if part of the heart is impacted and it's unable to, generate electrical impulse as well or conduct electrical impulse as well, that part can become an ectopic focus for cardiac arrhythmias. So that's the third point there, which is myocardial infarction. Then commonly the medications that we use to even treat these cardiac arrhythmias can actually precipitate them. Then other things that are correctable are stress, hormonal imbalances, and use of certain recreational drugs like cocaine, marijuana, all those can precipitate cardiac arrhythmias. So what the commonest presentations of these patients? So like I've tried to explain to you that when an electrical impulse is generated at the sinoatrial node, it flows down the atria then to the ventricles, and that's what generates a heartbeat. So in a case where this is impaired, the heart is unable to maintain a good cardiac output out of it. So that's what usually causes the patient to present to you, because they are unable to generate a good cardiac output to keep the organs perfused. So patients with cardiac arrhythmias will commonly present with an episode of syncope. They have dizziness, they have lightheadedness, because they're unable to, the heart is unable to generate a contractile force to pump blood out of it to the brain and have it perfused. So that's where the lightheadedness and the dizziness as well as syncope can come through. So because this heart is also not beating well, commonly these patients will present telling us that they're feeling their own heart beating. So because the normal flow of electrical activity is impaired, there are points that are generating abnormal impulses within the heart that could cause them to feel their own heartbeats, and that's what we call palpitations. So for a patient who comes to you and tells you, doctor or a nurse, I feel my heart beating, they could have a cardiac arrhythmia until proven otherwise. So again, for the other things like confusion, that's because the heart is barely getting any perfusion. So the patient will have mental confusion because of cerebral hypoperfusion. Then hypotension, still because the heart is unable to maintain a good cardiac output out of it. Then blood pressures drop, then cerebral perfusion also reduces, and that can culminate into the previous signs and symptoms I have talked about. So cardiac arrhythmias is generally a very broad topic that we cannot even talk about in a day or even a week. So we've tried to kind of make it brief by giving this broad classification of what cardiac arrhythmias are. So because I said it's how, a cardiac arrhythmia is any abnormality in conduction of impulses across the heart. So this abnormality can either cause the heart rhythm to be fast or to be slow. So that's why the general classification will give you those arrhythmias that are slow and those that are fast. So under the slow arrhythmias, we'll talk about those that are originating from the pacemaker itself, which is the sun, and those that are happening because there's an abnormality along the connection of the atria and the ventricles. That's the AV node. Then for the rapid ones, we'll talk about those that are originating above the ventricles and those that are originating within the ventricles themselves. So that's how broadly we look at cardiac arrhythmias. We look at them as those that are originating from the sinoatrial node, from the normal conduction pathway, or those that are originating from the AV node, or those that are originating above the ventricles or at the level of the ventricles. So there are like kind of two classifications according to the origin, according to the anatomical origin, and whether they are sinus or non-sinus. So we're going to go over them in a bit of detail, but this was just a general broad classification of things. So then we'll further classify the ones that are originating above the ventricles and the ones that are originating within the ventricles as supraventricular and ventricular tachycardias. So for the ones that are originating above the ventricles, there are quite many. They're called the supraventricular arrhythmias, and that's where anything that's originating from within the atria is going to be classified under. Even those that are originating at the level of the AV node, because the AV node is at the level of the junction of the atria and the ventricles, so those will be also classified under supraventricular tachycardias. Then for the ventricular tachycardias, there'll be those that are originating within the ventricles, and we'll go over all of them in just a bit. So how do arrhythmias arise? Just thought I needed to talk about this briefly. Like I said, arrhythmias can arise from the sinoatrial node, which is the point of origin of electrical impulses in a normal heart. So if there's a problem within the source, which is the sinoatrial node, those are what we call arrhythmias of sinus origin. If they're arising from any part outside the normal conduction pathway, those are the ones that we call ectopic rhythms. Then there could be a scenario also where the focus for the arrhythmia is outside the normal conduction pathway, but it's not a point that's just firing abnormal impulses, but rather it's a point where electrical impulses are making re-entry circuits. They make kind of tracks that allow them to recirculate within the same focus. So impulses, instead of flowing normally across the atria and the ventricles, there's a point either within the atria or the ventricles where impulses are just rotating around and causing a re-entry loop. So those are the ones that we call the re-entry rhythms. Then we have the conduction blocks. That's why impulses are not crossing over the ventricles, over the AV node, because of the problem with conduction. Then we have pre-excitation, where we have an abnormal bundle that's causing re-entry of impulses. So the arrhythmias that are arising from the sinus are quite many, but we'll briefly talk about the common ones. There's what we call a sinus arrhythmia. This is simply within a normal heart, and it just relates with the variation in beats due to respiration. So when a patient is inspiring, they'll have a rapid heart rate, and during expiration, rather when they're inspiring, the heart will go faster, and then during exhalation, it slows down a bit. So on a rhythm strip or an EKG, you'll see a strip that has beats that are kind of bundled together and rapid. Then the preceding beats or the proceeding beats will be a bit slower, because that's the point where the patient was expiring. Then it could also be a sinus tachycardia. This is where the heart is just simply going fast, but it's actually not an abnormality. There's an underlying cause that needs to be addressed. Then the sinus bradycardia is where the heart is just slow because the sinoatrial node is generating impulses at a slower rate than usual. So then there's a scenario where the sinoatrial node can completely go out of action. And if that happens, then we have any part along the conduction pathway taking over the generation of electrical impulses. So that can happen anywhere from the AV node, from the atria, from the internodal fibers, from the bundle branches, or from within the ventricles themselves. So conditions that could take the sinus out of action are things like an infarction, maybe an MI that knocks out the sinoatrial node, and so naturally the heart is made to have other cells take over in case the sinoatrial node loses its functionality. So that's what we call a sinus arrest, and we can either get a junctional escape beat or a ventricular escape beat. So let's go to what the gist of the discussion is. So like I said, we're going to talk about arrhythmias that are arising from the ventricles and arrhythmias that are arising from above the ventricles. So those that are rising above the ventricles are the supraventricular tachycardias or arrhythmias, and then those that are rising from within the ventricles are the ventricular arrhythmias. So like I said, anything above the ventricles is really happening either within the atria or within the AV node. So arrhythmias that are rising from there can be any of these. could be a premature atrial beat, it could be an AV nodal tachycardia, could be an atrial flutter, it could be an AFib, could be a multifocal atrial tachycardia or a focal atrial tachycardia. So just to briefly get into it, a premature beat is where a focus within the atria just takes over contraction. If the normal conduction pathway is not happening under the way it's supposed to be. So SVT, this is a very common arrhythmia. It's kind of a misnomer because in actual sense, it's not, yes, it's happening above the ventricles and it's encompassing all the SVTs, all the supraventricular tachycardias, but it was given this name because it's arising from above the ventricles. But however, to understand it exactly how it's happening, it should be an AV nodal reentry tachycardia. So here we have a reentry circuit, reentry rhythms happening around the AV node. So instead of electrical impulses flowing normally from the atria ventricles, from the atria, AV node, and the ventricles, we have reentry happening around the AV node. So that causes the heart to go very fast because where things are supposed to be slowed down at the AV node is where the reentry is happening. So that when that happens, we see a rhythm similar to this one below. So quite common each time you're evaluating a patient and you see such a rhythm, think of an SVT. The next presenter will talk about how this could be managed at the bedside and how referrals can be made in case your interventions are not helping. So F-flutter, also quite common, easy to recognize if it's a typical one, and how we like to talk about it is it gives a characteristic tooth pattern of the P wave. So the reason I put this diagram here on the right, this hand saw, is because this is how the sawtooth pattern appears. So you see P waves that are looking like these teeth of the hand saw. So it's what we're seeing here in the rhythm strip. We're seeing P waves that are just up and about from the baseline, and the QRS complex will be appearing a bit small, and the heart rate will be very rapid, anywhere between 150 to 200. So each time you're looking at a patient and you see such waves, think it's an atrial flutter. So this is what our patient had. It was an AFib, and AFib happens when there is abnormal electrical impulse, abnormal electrical generation within the atria. So you have multiple foci of electrical impulses within the atria. So what happens is the heart is just flowing chaotically. You don't see any easily discernible P wave because the impulses are rising from anywhere within the atria, not necessarily from within the AV node. So the atria are unable to contract and generate an atrial kick to push blood down into the ventricles. So that's why we see a very chaotic heartbeat, the way you see it appearing here. And it's going to be irregular because impulses are rising from random areas within the atria rather. And it will be narrow because it's arising from above the ventricles. So the QRS complexes appear small. Then this is quite common, multifocal atrial tachycardia. It's where impulses also arising from within different foci in the atria rather. And what we see is P waves of varying morphologies because they are generated from different points within the atria. And the heart rate will also be very rapid. So, I'm going up. So as I conclude, I'm going to talk about ventricular arrhythmias as well. So the distinguishing factor is at the point of origin of the arrhythmias. For the supraventricular, I say they're arising from anywhere above the ventricles, either the AV node or the atria. And for the ventricular arrhythmias, they're arising from within the ventricles. So what I like you to notice that for any rhythm that's arising from below the side, the atria, and that's within the ventricles, it's going to give you a wide QRS complex. So the distinguishing feature of non-EKG between supraventricular tachycardias and ventricular tachycardias will really be one of the things will be the size of the QRS complex. So for the ventricular rhythms, they will have a wide QRS complex because the impulse is being generated outside the normal generation structures, which is the atrium and the synovial node. So these ones are also quite many. I'll just go over the common ones. And one of the commonest is the PVC. So this will just, this simply appears as a big, wide, complex QRS that just appears randomly within the ECG rhythm. And it's usually very isolated and unrelated, having any structural resemblance to the other QRS complexes. So this is how it will appear. You see a normal QRS complex, then you go to one bizarre looking one. That's a PVC, and oftentimes they have no problem. We see them commonly in normal hearts, and they're usually, unsustained. You just see one, and it will not appear again. Then, so common also is what we call a ventricular tachycardia. This is where we have impulses arising from different parts of the ventricles, and it's really rapid. And like I said, because it's arising from the ventricles, it will be wide, and yeah, it will look bizarre, and it will have a QRS complex that's appearing very wide. So that's what it looks like. So each time you're evaluating a patient and you see a rhythm that looks like that, think of a ventricular tachycardia until proven otherwise. There are various forms, but for purposes of this presentation, we'll just talk about this monomorphic one, which is just having a common appearance for every QRS complex. So that's how it appears. Very bizarre, wide, and too rapid. So because it's too rapid, the heart is unable to relax and fill with blood. So the patient will be on the extreme end, will be hypotensive, and might get into shock because the heart is not filling with blood. Then ventricular fibrillation, also quite common. It kind of resembles what happens in AFib, but this time it's arising from the ventricles. So it's just chaotic bits of the ventricles. So, and because it's arising from the ventricles, it will be wide. And because it's also chaotic as the AFib is, there will be no clear baseline of the QRS complex. Each bit will be appearing different from the other. So the preceding one might be small, then the next one is bigger. There's really no baseline of what QRS complex is appearing. And this is incompatible with life. We see it in patients who are dying and they'll be arrested at that point. So these patients need to be defibrillated and CPR initiated for them. So then to sidestep one, quite common also, what this actually means are twisted points. It's also a ventricular tachyarrhythmia because it's going to appear wide, and it's almost always related to a prolonged QT, can be congenitally acquired, or can be congenital or acquired later in life. And really you cannot differentiate whether it's acquired or congenital non-EKG, but rather taking detailed history is what will help you ascertain this. Causes are quite many, but how it appears is this. It kind of resembles the AFib, the VFib, but the difference is that you have like kind of a pattern. You have points that are narrowing and widening at almost regular intervals. So that's what we describe as twisted ribbon. So if you've ever been to a church, those ribbons that they put maybe at the entrance, how they be twisted and rotating about, that's what the point appears like. So you see points of narrowing and widening across a rhythm strip. Yeah, so I'll just talk about conduction blocks as I conclude, because these are also parts of arrhythmias. Forms of arrhythmias. So I'll talk about the common ones, and that's the AV blocks. So there are three classes or types of AV blocks: type 1, type 2, and type 3. So, like I said, impulses are originating from the sun, getting into the AV node where they are slowed up for a bit, for about 200 microseconds, and then down into the ventricles. So at the level of the AV node where things are slowing up, the AV node could be dysfunctioning and slow, I mean, the conduction is slowed further. So when that happens, it happens at varying degrees and varying levels. So that's what causes the different types of AV blocks. So for the first type of AV block, there's just a delay in impulses getting down to the ventricles via the AV node. So what we see is just a prolonged ER interval, that segment between the P waves where the atria are contracting and the QRS where the ventricles are contracting. So there's just a bit of slowing and lengthening of that flat line. The normal one should be within 5 small boxes or 1 big box. But when you're looking at an EKG, as we see here, and that line is stretching more than 5 small boxes from the point where the P wave starts. That's a conduction block, and that's degree 1 if it's all repeated within the entire rhythm stream. Then, so for type 2, we have, I mean, for grade 2, second degree heart block, rather, we have 2 types. We have type 1 and type 2. So type 1 is where you have just, you have a prolonged PR interval until it doesn't get conducted. So what we see is you see a QRS complex and a P wave, a QRS complex and a P wave, but the P wave goes on lengthening until we don't see a QRS complex. So that's a second degree type. I mean, second degree. Yeah, that's a second degree. No, that's a type 2 second degree heart block. So that one is also compatible with life like the first one, may not need any interventions, and oftentimes it's coincidentally diagnosed when an ECG is done for other reasons. Then for type 2, for second degree type 2, we have random drops in QRS complexes. So this one is not very compatible with life and oftentimes needs a pacemaker. So what we see on an EKG is this. You see a QRS, a PQRS, until you will see a P and no QRS. Means there was no conduction at that point. Impulses go to the ventricles, go to the AV node, and instead of crossing down to the ventricles, they were just simply not conducted. So at that point, because the pause is going to be long, sometimes the ventricles, fire an impulse at that point. So you may see a QRS complex that's looking big and bizarre at that point. So for the third degree, this really needs an urgent pacemaker. There's really no association between what happens above in the ventricles, above in the atria and down in the ventricles. So impulses just simply get to the AV node and they never cross down to the ventricles. So that's where there's a complete blockage. Ventricles are contracting on their own. So this is what it looks like. So ventricles are contracting on their own, and because the rhythms are just arising on their own from the ventricles, the QRS complex will appear wide and bizarre looking, because what is making the ventricles to contract is not arising from the normal conduction pathway, which is the sun and down the ventricles through the AV node. But rather, if you are contracting on their own, so you see a P wave that's appearing isolated and a QRS that's just coming out bizarre on its own, because ventricles are not receiving impulses, but they decided to do something because they want to have the body perfused. So I'll stop at this point, but I just wanted to talk about this, which is also quite a common arrhythmia, the WPW. So WPW is where we have an abnormal bundle that's connecting the ventricle and the atria, the ventricles and the atria, called the bundle of Kenneth. So when, so this is congenitally present. So this is an arrhythmia that we tend to diagnose early in life. So this is what it looks like. So we see impulses coming down the AV node from the sun. But then at this point, we have a bundle on the right, which is the bundle of Kenneth. So impulses kind of rotate around this bundle. Instead of getting down to the ventricles and a normal pathway, they take this kind of recircuiting around the bundle of Kenneth. So that's what causes the racetracks and the abnormal impulses within the heart. So it can take two forms, either the orthodromic or the antidromic, but the characteristic ECG appearance will be a very fast heart rate with a wave that's abnormal, called a delta wave. So instead of the ECG appearing normal QRS, you see a rhythm that's very rapid and a QRS complex that's a bit of wide and having a wave before the QRS. So this is how it would typically look like. Wide, but then before the QRS, you see a wave before. Yeah, so that's what I wanted to talk about last. And I beg to stop at this point, and I'll hand you over back to the moderator. Thank you for listening.
Thank you so much, Dr. Kamoga, for the elaborate description of abnormal ECG rhythms. At this point in time, I want to allow only 2 questions, those that are burning. Do we have any? You raise up your hand. Do we have any burning questions that may have not been answered in the chat or in the Q&A? Okay, my teacher usually says if there is silence, they are okay. Oh, okay. Aisha, unmute yourself and ask your question. Aisha?
Thank you so much, Dr. Jensen. I'm sorry, I got this message and I got interested in this presentation. However, I've reached late when at least you've already, I've been a bit busy, but knowing that I would attend. So I have a patient, my relative, I will not disclose so much, who was diagnosed with a posterior spinal. And I thought I would benefit from this presentation for me to get to understand it in detail. And also, I'm also interested in knowing the nursing care.
Aisha, we ask you speak up. The expert hasn't got your question.
I have not enough network. My network is not so good. So I got a position that would enable me to ask my question. I have a patient, yes, and was diagnosed with a posterior spinal. And given the investigation that was done, I got interested, so much interested in getting to know or interpret the ECG, as well as getting to understand the nursing care that we can give to these patients while in the hospital and then the advice at home. Thank you.
Okay, so before you go off, the first part of your question got cut, but we got the last end. Can you type it in either the Q&A or in the chat?
I tried typing in the Q&A, but it wasn't opening for me. That's why I had to raise up my hand.
Okay, do it in the chat. Do it in the chat. We shall capture it and get back to you. Dr. Mary Ellen, do you have any questions you'd want to answer to at this point in time?
Yes, there was a particular question about the specific patient that I wasn't part of the care team, so couldn't answer. Let me see if I can find it quickly. Yeah, where is it? It was a
was it about cardioversion?
Well, it was why said that there was a determination of septic shock and there was hyperkalemia that wasn't mentioned. So wondering about that care, why there was no. They didn't mention giving calcium gluconate or the insulin dextrose for the hyperkalemia, and then also wondering how the the initial diagnosis of septic shock fit into the treatment? And perhaps whoever asked the question could chime in. I can't speak to this particular patient because I wasn't part of the care team.
Okay, so Dr. Kamoga was part of the care team. He can give a brief.
Yeah, so for why the hyperkalemia was not talked about in the case discussion. So these were results that were got after the patient had arrested and actually died. So we got the hyperkalemia, the electrolyte results during the postmortem report. So it was part of the postmortem evaluation for this particular case. That's why in the management, we don't make mention of anything like managing the hyperkalemia. We didn't recognize it until the patient had died. Then for the other question was about the sepsis. So for the sepsis, patient was already on antibiotics. So by the time when they arrested, we already knew they were in sepsis and were doing management for the sepsis as well. Yeah, I hope that answers your question.
Okay, so someone was saying, oh yes, Dr. Mary, you can go ahead.
Just to mention, I believe that an attempt was made to get the electrolytes. The result just didn't come back until after we'd lost the patient. Is that right?
Oh yeah, samples were taken off before, but then the results came back after. Yeah, we had lost the patient.
Yes.
Okay. All right. Okay. So thank you so much, everyone. Quickly, we are going to move to the next expert, and that will be Ms. Bethel. She'll be taking us through the pre-hospital approach to abnormal readings. You're welcome, Bethel.
Thank you. Thank you again for having me on here. Thank you, Dr. Dickson, for that very thorough presentation on EKGs. Obviously, it's a very big topic, so trying to cover it in a short period of time, it should be something that we all try and practice on our own time. So pre-hospital approach will be a little bit different here in Uganda just because some of the diagnostic tools are not always available on the ambulance. Am I correct? We usually have cardiac monitors on an ambulance. So the most definitive tool to usually figure out that someone is in an arrhythmia is putting them on a cardiac monitor, whether that's putting them on a 4-lead, which are the limb leads, so that you can read lead 2. And then if you need a better picture of what's happening in the heart, doing a 12-lead so that you can be able to see that. But because most ambulances don't usually have that for now, the best gift pre-hospital personnel can give to in-hospital personnel is good assessment and history taking. And so like we've rehearsed and said over and over again over the years that these sessions have been making sure that you're doing your ABPU, ABCDE on all your patients, but particularly with patients that you suspect cardiac issues, make sure that you're doing a thorough look at your pertinent positives and negatives. So when you're looking at chest pain, looking at the time that it started, what have they taken? Is this a chronic issue? Is it an acute issue? What are they doing that makes it better? What are they doing that makes it feel worse? Talking about the quality of pain, asking them to describe what their pain is like, how severe their pain is it radiating anywhere? Are they having shortness of breath? Are they having nausea and vomiting? When they tell you that it hurts right here in my chest, when you touch and palpate, are they saying you're having reproducible pain or not? Do you see JVD? Do you see edema? Do we see any of that? So for our pre-hospital personnel, and I believe with the EM residents that are sitting here, the best gift you can give them is getting a thorough history on your patient, making sure that you do quality assessment. Most of the times you are gonna have a long ride with these patients if you're bringing them from a facility or from their home. So things like pulse quality, being able to tell the doctor or the nurse when you get there that this is how their pulse feels like, is it strong or weak? Is it fast? Is it regular? Is it irregular? Those are things that are gonna help them know how to move quickly when they're trying to figure out what to do with the patient. So that would be my biggest point, is a thorough assessment, and making sure that for the things we can fix on the truck, making sure you can fix these underlying causes like Dr. Dickson had talked about. So if someone is stressed or hypertension, reassuring a patient, if you're able to give fluids, giving fluids, that sort of thing, giving them oxygen as needed, to make sure that you're able to keep them comfortable, but rushing them to the hospital. Making sure you're making a decision on the most appropriate facility to take this patient is also part of your assessment. So making sure you're making the best decision with that. And then I think the final thing would probably be making sure that you give a thorough and short report to your receiving facility so that they know what's the most pertinent information that they need to know in order for them to take care of this patient. So for pre-hospital personnel, it's the same thing that's just been reiterated over and over in every echo session. Thorough assessment is going to be your best thing. Making a good decision about the most appropriate facility, and making sure that you give a thorough and precise report to the receiving facility so that they can move quickly. So unless there's anything else, EM residents think that they would like pre-hospital people to let them know. I don't know. I think
Dr.
that's pretty thorough.
No.
Yeah.
I think basically.
Yeah, I think that's it.
Okay, thank you so much, Bethel, for the summary of pre-hospital. I hope our friends in pre-hospital, you picked that. Assess the patient, find out if they have an abnormal rhythm, and start on your management. Okay.
Oh, maybe just to say something. Bethel hinted about this. So in the ambulance, you're not going to have a 12-lead EKG, but you have a monitor at least with the 5 or 3 standard, cardiac monitor leads. So these can give you a full rhythm of the to represent what the cardiac conduction in the heart is. So that alone can actually be diagnostic for cardiac arrhythmia. You don't need a 12 standard EKG, 12-lead standard EKG to make a diagnosis of an arrhythmia. So just look at the rhythm strip, how it's running. Are there any delays? Are the QRS complexes wide? Are they narrow? And oftentimes, if you can't make a decision on your own, there's now technology. You can just capture the entire 1 minute, a 1 minute video of how the rhythm is running, and just share it with someone superior to you. Could be me, it could be anyone who is, a bit of more expertise in reading ECGs. Just share it with them, ask them to make a decision for you, to interpret it for you, and decide on what it is exactly the patient might need at that point. So you don't need a full 12-lead EKG to make a diagnosis of an arrhythmia in all circumstances. So look at the rhythm strip, take a picture of it if you're not sure exactly what it is, or a short video, share it with your superior so they can interpret it for you and make a decision for the patient. Yeah, that's what I wanted to just reemphasize.
Okay, thank you, Dickson. Any burning questions at this point in time before I introduce Dr. Bagonza? Any questions? You can raise your hand. Okay, as the person planning to ask a question is planning, we can have Dr. Bagonza unmute and give us the emergency management of abnormal rhythms, and how do we follow up our patients after they've reached the ED or from pre-hospital. Dr. Bagonza. Dr. Bagonza, are you there?
Good afternoon. Sorry, I was just sorting out something on my end. Can you hear me?
Yes,
Yeah.
you can.
Great. So my name is Bagonza. I am a visiting lecturer at University of Science and Technology. I'm also an emergency physician. And this afternoon, I'll be talking about pardon?
You can go ahead, Dr.
If you can't hear
Bagonza.
me, you can
We
hear me.
can
Good.
hear you. We
So,
can hear you.
yeah, good. So I'll be talking about initial management considerations in a patient who has an abnormal cardiac rhythm. And I think the previous speakers have really made my job very easy in terms of defining what an abnormal rhythm is and looking at some of the examples of the abnormal rhythms. So we will try and keep it very straightforward, and we will try as much as possible not to go into the details because it might get very long and confusing. However, I'll start with just a bit of the overview of the physiology and just help us understand why the physiology is important. Because someone might ask, so if someone has an abnormal rhythm, so what? I know so many people who have abnormal rhythms and they are walking around and they're fine. So really, it's about understanding that abnormal rhythms can have an impact on the hemodynamic status of a patient. And as we all know, the heart is a pump that provides the driving force that causes to move around within the vessels. So if the pump has issues, then you will have problems with flow of blood, and therefore you'll end up with problems of perfusion to different vital organs. So if you look at it, so we all know what the purpose of a blood pressure is, and we know what happens if you have a low blood pressure, and what will happen to the different organs in the body. So it's important to remember that from a physiological standpoint, when you're normal, that your blood pressure, which is necessary to maintain perfusion of your vital organs, is a product of the cardiac output and the systemic vascular resistance. That means that if something happens and there's a reduction in your cardiac output, your blood pressure will also reduce. The same goes for if there's reduction in systemic vascular resistance, you'll also have a reduction in the blood pressure and therefore perfusion. And when you take out cardiac output and you look at it a little bit more, essentially cardiac output, the definition is the amount of blood that the heart pumps out within the space of a minute. And cardiac output is a product of the stroke volume, which is how much blood does the heart push out in one stroke or in one squeeze, and you multiply this by the heart rate to be able to get a cardiac output. So from this equation, then you can tell that if a pathological state reduces the stroke volume, then there will be a reduction in cardiac output. And the same goes for if a pathological state reduces the heart rate, then you will also have a reduction in the cardiac output. And you can see where the problems might come from when you have bradycardia. Now, someone might say, okay, fine, what if the heart rate increases? Shouldn't the cardiac output increase? Now, what happens is, of course, as the heart rate increases from this formula, the cardiac output will increase, but that only happens up to a certain heart rate. Beyond a heart rate above that ideal heart rate, then you start developing problems. Because what happens if your heart is beating very fast, then there's not enough time for the heart to relax and fill with blood before squeezing it out. So eventually there will be inadequate filling, and that will affect the stroke volume, and ultimately you'll have a low cardiac output, and then you will have a reduction in blood pressure if the problem is not sorted out. Okay, so that's a brief of the physiology. So we need to understand how do abnormal rhythms present? Abnormal rhythms can present in a multitude of ways, okay? So the presentations are very many and very varied. Sometimes patients with abnormal heart rhythms can be asymptomatic, so they'll have no symptoms, and might be an incidental finding when a patient is in hospital for another problem, or someone notes it when they are resting, and they say, oh, I just noticed that my heart rate is beating abnormally, okay? But some other times they can present with features such as palpitations, lightheadedness, malaise, anxiety, and sometimes people will present with a complaint that can be very vague and can be very confusing and disturbing for a health worker. The patient can just present and say, I don't feel like myself. Or they'll, if that person is non-verbal, someone will say, well, he was not feeling like himself. He just did not feel all right. And that is as vague a presenting complaint as any can be. So that shows you that the presenting complaint or the presentation of patients with abnormal rhythms can be very many and very varied. And what does this mean for you as a clinician? It means that when you're looking at, when you see patients present to you these very vague, non-specific symptoms, always remember that when you're considering the differential diagnosis, think about abnormal rhythms as a potential cause of the patient's presentation. So obviously, remember that when you're in the emergency unit, the first thing you need to do is your initial assessment. And we've talked about these echo sessions that follow the ABCDE approach. The ABCDE approach will help you in a number of ways, but number one, it helps you be systematic, which will make sure that you capture all the important information that you need to capture, but also intervene where you need to. And the other thing is that it will help you be systematic and be able to provide management in a prioritized manner. So obviously in the ABCDE approach, you start with assessing the airway just to make sure that the patient's airway is patent. And if it is not, then we've talked about maneuvers before that you can carry out to make sure that you maintain airway patency. Then in B, you look at the patient's breathing and see, okay, are they saturating very well? Are they taking adequate breaths? Do they need supplemental oxygen, which you provide if they need it? And in circulation, remember that we've said that arrhythmias are essentially affecting the heart, so this would be mostly a circulation problem. In circulation, you try and find out, is there adequate perfusion? And if there's no adequate perfusion, what can I do about it? But also number two, you attach ECG leads, one, to make a diagnosis. Is it a bradyarrhythmia? Is it a tachyarrhythmia? And what type of arrhythmia is it? Based on the presentation that was made just before this. And then of course in D, you take off the patient's blood sugar and try to assess them and see if they have any lateralizing signs that might indicate problems that can present with abnormal rhythms, but they're not because the heart has a problem, as we will see. And then of course, lastly, the E, you expose the patient, take the patient's temperature. A lot of patients will have arrhythmias simply because they are either hyperthermic or they're hypothermic. So it's important to also take the patient's temperature. But you also, when you expose them, then you're able to see if they have any bite marks, which might present towards toxins, or if they have any injection marks, or if they have any features. Sometimes you might find a source of infection, for example, if sepsis is the cause of the arrhythmia that you're looking at. Okay. As you do your ABCDE assessment, you can take a quick history. This will normally depend on if your patient is stable. If they are stable, it allows you to be able to get a bit more of a detailed history. If they are not, you might only be able to obtain certain key features that are important for you to apply immediate management. So there are certain features that denote instability, okay? So if you have a patient who presents with an abnormal rhythm, whether it's a bradyarrhythmia or a tachyarrhythmia, if they have altered mental status, that is an unstable patient, because that means that there's a critical reduction in cerebral perfusion, which you need to address urgently. If the patient has pulmonary edema or has other features of heart failure, that's also a patient whom we term as unstable. So if they have an abnormal rhythm and they have pulmonary edema, so you listen to the lungs and they are crackles in the bases, or there are other features of heart failure, raised JVP, that's a patient who's unstable. And if a patient has syncope, if they have a transient loss of consciousness while in your presence, or even if they've had a history, so sometimes they'll bring them in hospital and say the patient collapsed at home. So even if they are conscious before you, if they've had a history of syncope, then that is a patient who's unstable. The other feature of instability is a patient who has ischemic chest pain. So if a patient presents with an abnormal rhythm and they have chest pain that is sort of synonymous with ischemia, myocardial ischemia, that's an unstable patient. And lastly, but not least, is if a patient presents with features of shock and they have an abnormal rhythm, then we consider them as unstable. So at this point, you might ask, why is it important for us to look for these features? Why is it important for us to know whether the patient is stable or unstable? Two things. If the patient is unstable, your approach to management and your priorities will be a bit different to if a patient is stable. Okay, so we will talk about, because unstable will require you to intervene. Even in an area where you may not have extra support, you will be required to intervene. Otherwise, the outcomes will be bad. But if they are stable, that allows you time to consult, to be able to call people who might not be at the place where you're assessing the patient to come and also have a look at the patient. But if they're unstable, you may not have the chance to be able to do all those things together. So we're going to talk about management of the unstable abnormal rhythms. We'll start with the unstable tachyarrhythmias. So number one, an important, there's a rule of thumb I like to use. All of us have the potential to become tachycardic. So if you exercised, or if you strained yourself, or if you are excited, you can get tachycardic. If you have an infection or a fever, you can also be tachycardic. However, there's a tachycardia that your body can handle, and if the heart rate goes beyond that number, then you start to get into problems of cardiac output and perfusion. So a general rule of thumb is that you take the number 220 and you subtract the patient's age. So let me say you are 20 years old. So if you're 20 years old, you might be able to tolerate a heart rate of up to 200 beats per minute. But if it gets beyond 200, then you start to get into significant problems. Okay, so if you have a patient who's 80 years old, that means they can only tolerate a tachycardia without getting into significant problems of up to 140 beats per minute. What does that mean? That means the older you get, the more likely you are to not be able to tolerate tachycardia, okay, very well. And another example is that, for example, in neonates, they can have a rate of up to 200 beats per minute and they're fine, okay? So remember, if a patient is very old, even if they have a heart rate of 140, they can actually present with very significant features of poor perfusion. But remember, we talk about this in a patient who's otherwise healthy. So if you have other underlying comorbidities, this number might even be lower than this average number provided here. So in unstable tachyarrhythmias, which are the very fast rhythms, of course, the couple of goals of care. Number one is you must terminate the rhythm. Of course, you've done your ABCD assessment. You've corrected the things that need to be corrected. If they need oxygen, you give them oxygen. Like this clinical case that was presented, the patient came in with atrial fibrillation. They had chronic atrial fibrillation, but they presented having decompensated. They have underlying rheumatic heart disease, but they also had features of sepsis. They had acute kidney injury. So this is a patient with a tachyarrhythmia, but they also have significant underlying comorbidities. And that, when you have a patient like this, whereas treating the tachyarrhythmia is important, you also need to think about the comorbidities, because this becomes a very complex patient because there are so many moving pieces in terms of disease processes, as well as the things that you need to manage. So one of your goals of care in the unstable patient should be to terminate the arrhythmia, because if it is the arrhythmia that is causing hemodynamic instability, then terminating it becomes very, very important. Okay. And once you deem the patient as having those 5 things we looked at that denote instability, then cardioversion for tachyarrhythmias would be your go-to intervention, electrical cardioversion. And you can do this using defibrillators. I know that some places may not have defibrillators, so that might be a bit challenging. But if you have a defibrillator, this is a chance where you use the defibrillator, but you need to be trained on how to use it safely, because you can hurt yourself in the process of using it, but you might also hurt your patient and your colleagues. So electrical cardioversion, we just generally deliver electrical energy into a patient, but in a synchronized manner. So synchronized essentially means that the point at which you deliver the energy, it has to be at a specific time within the cycle, the electrical cycle. And normally we synchronize the delivery of the shock with the R wave in the QRS. So when you look at the QRS complex where the R wave is happening, that's when we deliver the energy. Because if you deliver it outside that, then you might trigger other arrhythmias. And some of those arrhythmias may not be compatible with life, so you can cause a cardiac arrest. So all defibrillators that have a cardioversion option, usually there is a button which says synchronize. So once you press that button, then the machine will automatically synchronize. You select the energy that you need to use. And once you've ensured safety, then you go ahead and deliver the energy. And the machine will wait when the QRS is happening. So it does that automatically. Obviously, there are safety features that you need to take care of. You need to make sure that no one is on the bed. You need to make sure that the patient has received analgesia and has also been sedated. So this patient that they talked about in this case had received some ketamine. So ketamine has both sedation properties. It also has analgesic properties. So if you use a drug that can only sedate, then you need to give your patient some pain medication. And normally, it has to be, commonly we'll use opioids because drugs like paracetamol and NSAIDs will not cut it in terms of managing the pain. So once you've done that, we're assuming that you have obtained consent. Sometimes it may not be possible to obtain consent during this period because you're trying to intervene quickly. Then you go ahead and deliver the safe shock. So there are different energy recommendations for the different kinds of tachyarrhythmias. The doc presented to you that, you know, there are narrow complex tachyarrhythmias, there are wide complex tachyarrhythmias, there are those which are regular, there are those which are irregular, and these have different energy selection modes. So you deliver the energy, and what you're looking for is that you need to see the patient reverting back to their baseline rhythm, and then you continue monitoring them. So obviously, patients who have unstable tachyarrhythmias, even if they're bradyarrhythmias, you manage them in your resuscitation unit. So if you're in an emergency unit, you manage them in the place where you put your sickest patients. So this is where you have access to equipment, you also have access to monitoring, but you can also be able to provide the highest level of care. So don't have them on a regular consultation room. If you have some room which you termed as resuscitation, this is where you put your patient in the resuscitation room. If for some tachyarrhythmias, even when unstable, there is room for chemical cardioversion. So chemical cardioversion, you're using drugs, okay? And so one of the rhythms that is amenable to drugs, even when the patient is unstable, is supraventricular tachycardias. So the narrow complex regular tachyarrhythmia, that is amenable to certain drugs like adenosine. So you can quickly give adenosine as a fast-acting drug, and you assess for return of the baseline rhythm. If it hasn't returned, then you can rebolus with different doses of adenosine, which I will not talk about here because of time. If the patient is stable, now that's on the other hand, if the patient is stable, then you have a bit more room to play with in terms of, number one, diagnosing what tachyarrhythmia do they have. But number two also, outside of diagnosing what tachyarrhythmia they have, you have a chance to consult, and then you also have a chance to use other drugs that also terminate tachyarrhythmias, but they might do it in a more slower manner. So you might have a chance to give drugs like amiodarone and other agents that terminate tachyarrhythmias. So for example, digoxin for atrial fibrillation, some other antiarrhythmic agents like prilocaine, like lignocaine, and sometimes you even have room to use some beta blockers. So going on to the unstable bradyarrhythmia. So here the heart is very slow, and we've seen that the causes can be either a sinus problem, so you can have a sinus node dysfunction, which is what controls the rate, or you can have an AV node block. Commonly, it can be myocardial ischemia or infarction. So when you do a 12-lead ECG, trying to see is the underlying features of myocardial infarction or myocardial ischemia. So that might be something that requires a bit of a deep understanding of an ECG, but the initial priority is what is the rhythm, and then you can have other people look at it and say, okay, is there ischemia, is there infarction, and we need to do something about it. The other causes of bradyarrhythmia can be metabolic causes. So hyperkalemia is one of the common ones that causes bradyarrhythmias. It can also cause tachyarrhythmias, but terminally it will cause bradyarrhythmias. So in patients who are on dialysis or patients who have kidney injury, acute or chronic, always think about hyperkalemia as a potential cause of the abnormal rhythms that you're looking at. The other metabolic cause is thyroid problems. So if you have a patient who has hypothyroidism, they might also have, they may present with bradyarrhythmias. The other cause, which you will find in the E, is normally patients who are hypothermic. So they may also present with bradyarrhythmias, okay? And then the infectious causes of bradyarrhythmias, these can be infections that involve the heart. Commonly, some certain viruses can cause myocarditis as well as pericarditis that can present with bradyarrhythmias or tachyarrhythmias. And then the others are things like syphilis, which can also cause myocarditis. Sometimes the infection is not active, but in the post-infection phase, a patient can present with the abnormal rhythm because of an infection that has recently subsided. Then, of course, you have toxicological causes. And these are very many, but commonly it is prescription drugs, okay? So if you have a patient who's hypertensive, who is on beta blockers or a combination of beta blockers, they're at risk of having poisoning from their prescription medication. The other one is patients who are on digoxin. So if they're on digoxin as treatment for atrial fibrillation, they can present with digoxin poisoning, which will come in with bradycardia. So always ask, does the patient have an underlying condition and what medication are they taking? And you try and figure out, okay, might this medication explain why this patient has a bradyarrhythmia, okay? And then there are other distant causes of bradyarrhythmia. So you can have intracranial events that can present with bradyarrhythmias. So if you have increased intracranial pressure from whatever cause, you might have bradyarrhythmias, okay? You can also have intracranial bleeding, intracranial tumors, infections, intracranial infections like meningitis that can cause increased intracranial pressure, and your patients will present with bradyarrhythmias. The other place that we rarely think about, but is also a common cause of bradyarrhythmias, is patients who have intra-abdominal pathology. So patients with intra-abdominal pathology can also present with bradyarrhythmias, commonly intra-abdominal hemorrhage. And then you have patients who have hypersensitive carotid sinuses. So some people, just simple carotid massage can cause them to develop a bradyarrhythmia. So it's always good to think about all these things. But importantly, of course, if your patient is unstable, you first manage them, and then you start to obtain a bit more history later. Remember, when this patient comes to you, you've done the ABCDE assessment, ask them if they have any drug allergies, because you might want to use drugs that they might be allergic to. Obtain IV access, because that's very, very important, because there are drugs that you might want to give. You might want to give some fluids, for example, but also it helps you have IV access in case the patient deteriorates and has a cardiac arrest and you need to give them drugs. So management of bradyarrhythmias is stepwise. Commonly we'll start, there's an algorithm that you can follow, and you can do some further reading on this. There are European Resuscitation Council guidelines. There are also American Heart Association guidelines. Some of your facilities might have some of these guidelines that are a variation on the ones I've just mentioned. So the first thing we normally do is we give.
I appreciate it, sir.
Yeah. Maybe the other thing I haven't talked about, because it's fairly common in setting, is patients who are poisoned by organophosphates. Some of them will present with bradycardias. So Initial management, normally we give atropine. So depending on the source that you read, some sources will tell you give atropine 0.5 milligram, and then you repeat this after about 3 to 5 minutes, another 0.5 milligram, up to a total of 3 milligrams. There have been some modifications to some guidelines. Some of them now recommend that you give 1 milligram, and you repeat this every 3 to 5 minutes up to a total of 3 milligrams. So if you're giving 0.5 milligram, you can repeat this every 3 to 5 minutes, a total of 6 times. That's 3 milligrams if you're giving 0.5 milligram. If you're giving 1 milligram, that means you can do this up to 3 times. So if you get to 3 milligrams, then you stop there. You need to use other agents. So in the clinical setting, the behavior is that usually you'll give a patient atropine, the heart rate will increase, but then it will start to go down again. Okay, then you give another bolus of atropine, the heart rate increases, then it starts to go down again. So usually, by the time I've given the second atropine, I am planning on other management modalities because I know atropine is not going to cut it, because it's just giving me transient increases in heart rate. Okay, so remember that so the other agents you can use is isoprenaline. I don't know how many of us have seen isoprenaline or even have access to isoprenaline. Adrenaline is fairly more common, but it is a it's a very dangerous drug. It's very helpful, is life-saving, but if used inappropriately can create bigger problems. So normally we dilute our adrenaline, and we normally, the dosage is 2 to 10 micrograms per minute. So it's an infusion of 2 to 10 micrograms per minute. One vial of adrenaline has 1,000 micrograms. So if you put that in a bottle of 500 mils of normal saline, you'll have 2 micrograms per meal. So if your dose that you want to give is 2 micrograms per minute, then you will need to give that patient a meal per minute. And if you need to increase to 4 micrograms per minute, then you'll increase to 2 meals per minute. And but if you have an infusion pump or you have a syringe pump, this makes your life a little bit easy, because then you're a bit more accurate with the dosing. If you don't, then just remember that you can look at your giving set. Most giving sets, 20 drops are 1 meal. Some others, 25 drops are 1 meal. So you then do that calculation and find out how much you need to give. Okay. And as you do this, of course, you're trying to find what the underlying cause is. And once the heart rate increases, then you start to assess the patient for features of improvement. So if they presented with altered mental status, is their mental status improving? If they had cold extremities and their blood pressure was low, is the blood pressure increasing? Are their extremities getting warmer? If you have them long enough, then you ask yourself, okay, is urine output improving? Because then that means that there's increased renal perfusion, okay? Because you're correcting the primary problem. The other question, of course, you ask yourself is, okay, the patient has a bradyarrhythmia. I have corrected the bradyarrhythmia, or I'm correcting it, but what triggered the bradyarrhythmia? So if a patient took a toxic agent, then you need to find out, does this agent have an antidote, and can I give the antidote? If the patient has hyperkalemia, for example, they're a dialysis patient and maybe missed a session, or they're newly diagnosed, you ask yourself the question, okay, can I begin management for hyperkalemia? And we know you give insulin, you give dextrose, and you can also give some sodium bicarbonate, okay? So it's important to understand what is the reason behind the bradyarrhythmia, because then you can start also correcting that concurrently. Then lastly, if these things fail, or you anticipate that they will not work very well, ultimately the patient will require pacing. So pacing is a bit of a specialist intervention. You can do, so there are 2 types of pacing. Is basically you're taking over, you're going to set the rate at which the heart is beating, because it's beating too slow. You want to use an external piece of equipment to set the heart rate at which the heart should beat. So you can do this in a number of ways. One, you can do it transcutaneous. So transcutaneous is basically you're pacing through the skin, okay? The other way that you can do it is transvenous. And in transvenous, normally they will get IV access. Then they'll float a catheter there with an electrode on the end of the catheter, a specialized catheter, which will go all the way to the right ventricle of the heart, and then they'll start pacing. That is transvenous pacing. And then, of course, ultimately, the ultimate management would be inserting a pacemaker for these patients, which would, in a setting, would happen at the Uganda Heart Institute. The other thing is that most times, most places may not have the capacity or the expertise to be able to do transvenous pacing in the emergency unit. So then you're left with transcutaneous pacing. So most defibrillators, modern defibrillators, have a pacing function. So it's a defibrillator, but it can also pace. So it's just about you pressing the right knobs and switching it from defibrillator mode to pacing mode. And however, the challenge is that it will require pads. So in most of our settings, we have paddles, the ones that are attached to the defibrillator, the big solid ones, the ones that you put on the patient's chest with your hands. However, there are those that are like ECG leads. They're a bit big and flat. They're like ECG leads, and they are sticky. So you attach them to the patient's chest. And normally you would attach them in the same areas where you would put the defibrillator pads. So one pad under the right clavicle and another pad in the apical area of the heart. And once you've put these pads, same thing, of course, you have to obtain the patient's consent. You might need to give them some analgesia because as the shock is being delivered, it can be painful. It's not as painful as what you do for cardioversion, but it's also very uncomfortable because it causes muscle twitching, and this can be uncomfortable for your patient. So once you've connected this, then you select the pacing rate on your machine. So normally if the patient, we will start with 60, because 60 is the lowest normal blood pressure, lowest acceptable normal blood pressure. So you will start at 60 because you don't want to have a patient who has a heart rate of 35 and you take them immediately to 80 because you will cause them problems. So you start at 60, and there's a whole process to pacing. Essentially, you're looking for electrical capture, looking for physiological capture, until now the heart begins responding to your external pacemaking. And obviously, of course, once you start pacemaking, if there's a reversible cause, then you start addressing the reversible cause. If you can't find a reversible cause, of course, you're planning for a transfer to places where they can do more investigations, but as well as ongoing care for this patient. So all these patients are at risk of deteriorating and suffering from a cardiac arrest. So you have to treat them very urgently. They need continuous monitoring, and you have to, as early as you can, get the expertise help that you need. Okay, let's move on to the next slide. So if your patient is stable, then you can do a couple of more diagnostics. So take a detailed history about some of the things we've talked about, obtain a 12-lead ECG, look at the rhythm, assess for features of ischemia if you can. Then, of course, we said that usually these abnormal rhythms are triggered by something baseline. So always remember, check for electrolytes, especially magnesium, potassium, and calcium. Remember, check the troponins if you're concerned about ischemia. If you're able to do a blood gas analysis, look at that because it can tell you about patient's pH. It might also be able to give you some electrolytes, and it's at the point, it's at the patient's bedside. So you get results much faster than if you send electrolytes to the lab. Check thyroid function, because hyperthyroidism can give you tachyarrhythmias. Hypothyroidism can give you bradyarrhythmias. So check thyroid function. Remember to also do urea and creatinine, because if you find the patient has AKI, then this might be contributing to the presentation. Then there are other causes of tachyarrhythmias. For example, if you have a pheochromocytoma, which is a tumor in the adrenal glands, there's a test where you look for the breakdown products of these catecholamines in the urine. It's called urine vanillyl mandelic acid. You can check the urine for this, but this you'll get the results after a long period of time. So they may not be very helpful for you in the acute care setting, okay? But it's good to get these tests off early so that the guys who are going to continue management of this patient after you have intervened initially can get the results as quickly as possible. Then the others are pro-BNP, which looks for features of heart failure. And then you can see in the very small print, you do toxicological screening. The results will take very long, might not even be very helpful because they take a while to come back. And then imaging as well, okay? Let's move on to the next slide. And then, of course, remember, ask for expert help early. Of course, if the patient is unstable, ask for help, but you need to start doing something as you wait for the help to come. So get access to a physician if you can. Sometimes even when they're over the phone and you're sharing images on WhatsApp, they can be able to guide some of the things you can do as you prepare to refer, if at all referral is the best course of action to take. If you have access to a cardiologist, you do the same. And then of course, disposition will depend on a number of factors. Disposition is essentially where are we sending the patient after. So there are some arrhythmias, once you manage them, then you can send the patient home safely. There are arrhythmias, once you manage a patient, even after it has terminated, you need to admit them for monitoring as well as workup. So there are a number of factors. So for example, if a patient comes in with SVT and you have investigated them for the most likely causes and they're a young person, you can safely send them home after having them be assessed by somebody within the emergency unit. However, if a patient is older, they have a number of comorbidities, they are taking a number of drugs, these are people you might need to admit for them to be worked up appropriately. So disposition will depend on by a number of clinical factors as well as the patient factors. So whether to admit on a general ward or in the ICU will also depend on the general clinical status of the patient. So going back to the case presentation, that patient that we had with atrial fibrillation, AKI, sepsis, underlying rheumatic heart disease, had been in the hospital previously before that admission, which was presented. That's a patient ideally, even if you've terminated the AFib, that's a patient who should be admitted to the ICU for further monitoring as well, because they're at risk of going back into AFib. Now, rhythms like AFib, if there's an underlying structural problem, like in rheumatic heart disease or valvular heart disease, those are patients, even when you terminate the AFib, they will quickly go back into AFib. Some of them, you can even shock them, but they will never get out of the AFib, and you can get quite frustrated. So we need to think about other modes of management. So, and then lastly, last slide. Remember that there are some pearls and pitfalls that we need to think about. So remember, systematic approach, recognize the hemodynamic consequences of the rhythm, because that's what brings patients to the hospital most of the time. Remember to avoid simply treating symptoms, but find the cause of the tachy or bradycardia. And then remember, of course, the precipitants. So it can be toxidromes, hypoxia also, ischemia, medication side effects, metabolic abnormalities, heart disease, pulmonary disease. It can be intracranial disease, non-compliance to drugs. It can be abdominal disease, okay? And don't take any patient you see with a tachy or a bradyarrhythmia for granted. Always give them the benefit of the doubt, even when they come to you and they seem asymptomatic in that moment, because it is usually a reason why they've come to the hospital. With that, I'll stop there.
Thank you so much, Dr. Bagonza. That was quite elaborate. I hope all of us were wondering how to approach a patient with an abnormal rhythm or do it. There you go. Dr. Bagonza has tried to simplify it to the basic minimum. Any burning questions at that point in time? I'll allow two for the sake of time. Any burning questions? Okay, just like I said, that's the question. Yes, Dr. Makerere?
I had a few people asking if, I wonder, Dr. Bagonza, if you could just go over again what you were saying about the dilution. And I've tried to make the point that when you're making a dilution, it's often very important, if you can, to check with a colleague to make sure, because it's very easy to make mathematical mistakes in a high stress situation. But if you could perhaps go back over the dilution of adrenaline, that was a big question for several participants.
Okay, so thanks, no problem. So remember, if you think in your head that I need to give adrenaline, if you've never given it before, please consult, okay? Because if you wrongly give it, you will create an even bigger problem. And I have seen this several times. You try to give adrenaline with the best of intentions, but then you cause bigger problems for your patient, okay? So the dose for bradyarrhythmias when you're using adrenaline is 2 micrograms to 10 micrograms per minute, okay? 1 vial of adrenaline has 1,000 micrograms, okay? So what we usually do in a setting where you don't have infusion pumps or syringe pumps, you'll get that 1 vial and put it in 500 mils of normal saline or Ringer's lactate, whichever. Now, because there are 1,000 micrograms, because it's 1 milligram, which is equal to 1,000 micrograms, those 1,000 micrograms divided by 500 mils of the fluid which you're using, that means for every mil of that fluid, there are 2 micrograms of adrenaline. So if the dose you need to give is 2 micrograms per minute, then that means you'll be giving your fluid at 1 mil per minute. And I said, most infusion sets in Uganda are 20 mils, 20 drops per mil. Some of them are 25 drops per mil. If you're not sure, you can check the packaging of the giving set. It will tell you how many drops are in a meal. So if it's 20 drops per meal, if you're giving 2 micrograms per minute, then you'll be giving 20 drops per minute. So you get your watch out, you time, and then you start counting the drops. So it must be 20 drops in a minute. You'll be giving 2 micrograms per minute. If you need to increase this dose because you're not seeing the response that you want to see, which is an increase in the heart rate and improvement of perfusion, then you can increase to 3 mics per minute, 4 mics, 5, 6, 7, up to a maximum of 10 mics per minute. All right. So some patients will have problems with fluid. So there might be patients in whom if you give too much fluid, then you'll cause them problems. So in patients like those ones, then you might need to increase the concentration of adrenaline in the fluid, okay? But a general rule of thumb is 1 vial in 500 mils. And then you can adjust that to the dose of adrenaline that you want to give. But please consult as you do this. Thank you.
Thank you, Dr. Bagonza. Dr. Mary Ellen, do you have any other concerns?
Not offhand. There was a question of someone who had mentioned, but we give much higher doses in cardiac arrest. And just to make the point that dosing of adrenaline in cardiac arrest, which is a patient that has died, is completely different than a therapeutic dose for a living patient. So many of us are very aware that we give a milligram of adrenaline every few minutes when we're trying to resuscitate a patient whose heart has stopped. That is completely different than the dosing for a living patient with whom we're doing a therapy. And I think that's part of Dr. Bagonza's saying. We have seen cases where that difference has been misunderstood in the past. So just be very careful with these critical medicines. They save lives, but we need to be very careful and often to consult with a colleague before moving forward in a stressful situation.
Okay, thank you so much. Any other burning issues? If not, I request Donato to take us through the nursing care of a patient with an abnormal arrhythmia.
Thank you so much once again for this opportunity. The topic is a bit broad, but I'll try to summarize it. Otherwise, nursing management for patients with abnormal heart rhythms is a bit broad. I'll divide it into two. I will divide it into patients who are stable and patients who are not stable, unstable. For patients who are stable, before I reach there, the goal of nursing management usually is, the goal is to improve the cardiac output. So if you are to improve the cardiac output, there are certain things we have to do as nurses and then plus other professions for these patients. So for stable patients, one, we shall first and foremost, these patients, when they are told, they become anxious. They think they are going to die right away. So first and foremost is to calm them down. You can tell them, this is okay, you're going to be fine. Reassure them. Secondly, let's do ABC. As nurses, we do ABC also. Thirdly, to rule out life-threatening events, monitor the vitals, monitor the pulse. I don't mean like attaching on the monitor but physical monitoring changes. If, for example, you pet the patient and the monitor is showing that you're pacing at 70, do you have the heart rate mechanically at 70? Yes. If we have mechanically the heart rate at 70, then that's fine. Let's take that one. If we are cardioverted and the heart is showing there is a normal sinus rhythm, when you feel the pulse, is it normal? Is it the regular pulse we feel? So that's for monitoring the patients. Let's monitor their blood pressures. This will help us to identify them early and inform the concerned physician or cardiologist. For example, when there is a drop in blood pressure, these patients, if the patient has been stable, we start taking them to be unstable. Then for unstable patients, we are going to use a synonym. If they are admitted in ICU, it's called fast hearts in bed, BID. So you can go to the last slide, fast hearts, BID. Yes, there. So first, for example, the patients in ICU, if they are not feeding, if they are intubated, they are in an energy tube. If they are having an energy tube, let's feed them accordingly. If they are sedated, let's make sure they are sedated very well. Let's maintain the doses of sedations. Let's maintain the infusions. Because once these patients come out of the sedation, they are going to remove our tube, remove everything, and everything will go with bazaar. Then analgesia, as they said, this cardioversion defibrillation usually inflicts pain. If we are doing cardioversion, let's give analgesia, and probably, usually what commonly used, we use fentanyl or opioids to give analgesia. Then let's do thromboembolic prophylaxis. Usually for rhythms like AFib, even if the patient is stable, they usually put on thromboembolic prophylaxis. And I think let's make sure they are taking their medications. Some patients are not adherent if not told. They need to be explained to well how these medications have to be taken and their importance so that they can understand. So if they are completely sedated, in ICU, let's make sure we give them their dose of clavicula, their enoxaparin, or if they are on unfractionated heparin, let's make sure we give them in time. Let's make sure the head of the bed is raised to prevent alleviating other ICP and other pressures. So let's control ulcer. If they're in ICU, again, or they are at A&E, these drugs, these rhythms and diagnoses and the interventions and the way we approach patients, they bring out so much stress to these patients. So patients may end up getting stress ulcers, and they also may end up getting, if they are completely sedated, they may end up getting pressure flowers. So we need to control both. For stress ulcers, we are going to give a PPI, and then for bed sores, we are going to ensure that we are turning the patients every 2 hours. And if that's not possible, let's ensure that we get for them pressure mattresses. Then that's all ulcer control. Glycemic control, if the patients are completely sedated, there is a high chance that we are going to do either under or overnutrition. So let's make sure their blood sugar levels are in range. Next slide. Then for S is spontaneous breathing trial. For patients who are intubated, we are going to make sure that it's either we are going to make sure that it's either when we approve some improvement, if there is some improvement, to check whether they can breathe on their own. We can switch off their ventilator and see whether they can breathe on their own. Then we are going to do bladder and bowel controls, either with indwelling catheter, with pampers, and other. Then the indwelling catheter removal, if we achieve if we have achieved a bit of improvement and these patients we feel can do activities on their own, we can remove the catheters because the catheters may be another source of infection. So we can also do the de-escalation of antibiotics, which is also important. For example, this find the patient has been like on 4 antibiotics, which we reduce like to 2 or 1 and see whether the improvement to allow the immune system to work on its own. Then that's for patients who are in ICU. Then again, when the patients improve and they are outside the hospital, we can monitor their heart rates using a Holter. Then we can also do continuous labs. We make sure we monitor we do nursing visits. We can also monitor how they are taking drugs. Those are for patients who come in usually as outpatient. I think that's all. Otherwise, the topic is a bit broad to be broken down into small pieces. Thank you.
Thank you so much, Donato. Questions will continue to be answered in the chat. I'll ask Bethel to return and quickly help us run through. If I have an ECG paper in front of me, what do I need to do? I know most of us look at it and we are scared from the word go. So she's just going to give us a run through of how you can approach interpretation of ECGs. Thank you, Bethel.
Okay, so I have about a 6-step method that you can use. I'm gonna pull up a EKG so that we can follow along. And then you can always find EKGs on YouTube and things like that and just practice this kind of systematic way of going through it. So just like Dr. Dickson had talked about in his presentation, you're gonna have what we call a P wave, then you have the PR interval, then you have the QRS wave, then you have the T wave. So when you're looking at an EKG strip, the first thing we want to try and figure out is the heart rate. Most monitors give you the heart rate or it's written at the very top or anything like that. But if you wanted to know quickly how to get a quick heart rate, you take the 2 R waves, which are the tallest peaks of the QRS complex. I don't know if, yeah, that one right there, that you get 2 R waves and you count the big, large boxes between them. So if you go through, you can see how many large boxes are in between those 2 R waves, and you get 300, the number 300 divided by that number should give you a quick overview of what that, yes, we'll give you a quick overview of what that is, of what your heart rate should be. So if you look at the last 2 R waves on this EKG strip, they're perfectly put together. There's 3 large red boxes in between them. So 300 divided by 3 gives me about gives me 100. So I can say this is about a heart rate of 100. But again, most of the times we have a cardiac monitor or you have a pulsometer on your patient. So you go ahead and you do that. So heart rate is the first thing we look at. The next thing we look at is regularity, right? So Dr. Dickson and Dr. Kenneth talked about regular and irregular rhythms. What you're gonna do, which would be easy, is to get a piece of paper or anything like that, and you mark, again, these R waves. So you mark 1 R wave, and then you mark the 2nd R wave. And then you go through the entire strip, trying to make sure that each R wave marks up on those markers. That way you can sense and guess that you probably have a regular rhythm. If you can't obviously see it in front of you, that's a good way to mark to see if you have a regular rhythm or not. We've done heart rate and we've done regularity. The next thing to look at is the P wave. So as we were taught earlier, the P wave is a sign of atrial depolarization. So that's that wave right there. Typically, when we see it, we have a quick understanding that our sinoatrial node is functioning properly. At least we know that the signal that's coming through the conducting pathway is originating from the sinoatrial node. So when you see a P wave, you can assume that you're having a sinus rhythm. What P waves need to be, they need to be upright, they need to be kind of rounded, and they need to look pretty regular throughout the strip. They're not gonna look perfect each way, but they need to look at least symmetrical and look about the same throughout the strip. And that's how you know you have a good P wave. So for this case, we have a P wave and it's upright. It looks kind of symmetrical, and I would say that the P wave looks pretty much the same throughout the strip. I don't know if the cursor is this, oh, there it is. So the P wave looks about the same throughout the strip. So this is what I'm looking at. And the other thing we want to make sure is that every P wave is followed by a QRS wave. So if we see that every P wave is followed by a QRS wave, then we know that we at least know we are having good atrial depolarization. So we've looked at heart rate, we said heart rate is 100, looked at regularity, we said this rhythm is regular, and the P wave looks normal. And because we have a P wave and it's present throughout the rhythm, I can call this a sinus rhythm. Then the next thing we're gonna look at is the PR interval. Now, to go over the PR interval, if you remember in the lecture that Dr. Dickson gave, he kept talking about boxes, the number of boxes. So most EKG strips have what you see here, have a large, like this large, really outlined red box. And in it, you see little tiny small red boxes. So each tiny small red box, get a small red box and say on the x-axis and the y-axis. So on the x-axis, we're looking at seconds. And then on the y-axis, we're looking at voltage. So those really small red boxes within the big red box, the x-axis is 0.04 seconds or 40 milliseconds. And then the big red box that they all sit in, the x-axis is 0.2 seconds or 200 milliseconds. So when we're looking at the PR interval, you will see us typically say that we want a PR interval that's no greater than 0.2 seconds. So a PR interval that's not greater than one large red box. That's what we call a normal PR interval. So we want a PR interval that's not greater than one large red box. So you have to come through, sorry, the cursor is a bit finicky, but you want to come through. And remember, the PR interval is not just the PR segment. So people confuse that a lot. The PR segment is just that straight isoelectric line that Dr. Dickson talked about before. Your PR interval starts from the beginning of your P wave all the way to the end of the PR segment. So those are the tiny boxes you're counting to make sure that they fall within that time length of 0.2 seconds or below. So with this one, I don't know if I can see all the way through here, but this is a normal PR interval. It's less than one red box, okay? From there, we then look at the QRS complex. So this is that entire wave right here, with the Q wave being a downward deflection, R wave being upwards deflection, and S wave being downwards deflection. All we want to make sure, again, is that your QRS wave is following that pattern: downward Q, upward R deflection, downward S deflection, and that the length of your QRS wave is no greater than 0.12 seconds. So if you remember, Dr. Dickson talked about how rhythms that originate above the ventricles tend to have narrow QRSs, and then rhythms that originate from the ventricles have larger QRSs. So when we have QRSs that are larger than 0.12 seconds, which would be 3 small boxes, because remember, each tiny box has an x-axis length of 0.04. So 3 small boxes, then we know that that particular ventricular rhythm is not coming from above, is coming from the ventricles if it's larger than 0.12 seconds. So again, we want to make sure that it's not no more than 0.12 seconds, and every QRS is preceded by a P wave. So there should be a P wave before a QRS complex and a QRS complex after a P wave. And typically, that's all you need to be able to tell what kind of underlying rhythm you have. The ST segment and the T wave tend to be more diagnostic. We'll see people look at the ST segment to kind of decide whether we're having ischemia or infarct when we're looking at depression and elevation, which we can't tell. We can't commit to when we just see it in one lead. So this is when we typically do a 12 lead. So if you notice some elevation when you put them on the 4 lead, then you should probably be pushed to say we should probably do a 12 lead. But we can't determine that someone is having an infarct by just looking at one lead when we're doing these. So ST segment is typically for diagnosis purposes, and then your T wave also will give you diagnostic. You don't necessarily need it to determine what kind of rhythm that you're looking at, just on the basic level. So you can go and look up some strips and just practice looking at heart rate, determining if you have a normal P wave, a normal QRS wave, a normal PR interval, and that can kind of help you learn how to read EKGs and then distribute them in all the different tachyarrhythmias, bradyarrhythmias that we've learned today. But one big thing to make sure that you reiterate, and I think we've reiterated this a lot, is we treat the patient and not the monitor. So the EKG is just another tool in your toolbox. It's a piece to the puzzle. You don't just use that to determine how to treat your patient. So when you figured it out, make sure you put it together with everything else you have going on to try and figure out how to treat your patient. So that was very quick, but I think it at least gives us an idea of what we're looking for when we're looking at an EKG. Someone else has anything else to add?
All right, thank you so much, Bethel. So it's not intended to be the ultimate, but that's briefly what you look at as you are approaching an ECG or a patient who comes to you with an ECG, or if you do one. So quickly, Dickson will give us a take-home message in 1 minute, as well as Dr. Bagonza and Donato in 1 minute, each one of us.
Yeah. Thank you, Connie. So as we come to the end of this, I'd like to really emphasize this to the teams that offer pre-hospital care. And I'll base this on the point that I've already made. So each time you're managing a patient within that ambulance and you're thinking it's a cardiac problem, I know it's not routine practice for us out there to connect these patients on cardiac monitors, simply because one, we think the interpretation is very gross and tends to get over our heads. So it's important that every time you're in that ambulance, you're moving a patient, really irrespective of what condition they could be having, hook them on that monitor, have that rhythm strip running, make sure you look over it, make an interpretation out of it. And like I said, if you can't really interpret it so well, but again, at the back of your mind, you think the patient has a cardiac problem, take a video of it, send it via WhatsApp to someone who can make an interpretation of it. You can do that during transit. It doesn't necessarily have to be when you get to the hospital or towards the point where you're getting to the hospital. You can do it even the moment you load the patient on the ambulance. So that rhythm strip is very diagnostic for cardiac arrhythmias. It doesn't always need you to put the patient on a full lead EKG. So have that rhythm strip running, make an interpretation of it, send it to someone who can make a good interpretation out of it if you can't do it yourself. Then also one last thing that I'd like to make a comment about is what Aisha asks. She wondered what a posterior STEMI is and what nursing care options are there for a patient, because she says that she has a relative who suffered a posterior STEMI and she really just wants to understand what it is. So just to give you a brief meaning to this, So a posterior STEMI happens when you have an occlusion of a vessel that supplies the posterior aspect of the heart. So what happens is that a particular part of the heart dies out or gets infected because it's not getting that supply to it. So the problem